My name is Elliot Williams, and I'm the training manager at the National Press Club Journalism Institute. Before we begin, I'd like to note that we are recording this program. Highlights will appear on our website and in our daily newsletter for journalists, which you can subscribe to using the link in the chat. Of course, as always, feel free to submit questions using the chat or Q&A feature, and your questions will be addressed at the end of our program. And let us know in the chat where you're tuning in from. When we talk about public health, we often take a big picture approach. We look at major statistics like national averages, overall spending, broad policy shifts. But those numbers don't always capture the fact that there's a widening divide between healthcare options in urban and less densely populated rural communities. Rural Americans face unique barriers to quality healthcare delivery, from cancer treatment to maternal care. And today, we'll examine not just the scope of these disparities, but how we as journalists can better tell these stories. We're fortunate today to learn from Dr. Zink, who is the state of Alaska's former chief medical officer and current senior fellow at the Yale School of Public Health. Dr. Zink is recognized nationally for implementing research-driven healthcare solutions and advocating for health improvements at local, tribal, territorial, state, and national levels. During the early stages of the COVID-19 pandemic, the Associated Press referred to Dr. Zink as the explainer-in-chief, as she provided regular updates to the public in a straightforward, easy-to-understand manner. Dr. Zink, thank you so much for being here and for sharing your expertise with us. And with that, I'll hand it over to you.
Yeah, well, it's really, really wonderful to be here. And Elliot, thank you for the opportunity to come and for the introduction. I got to see some of the work that the different fellows were doing, and I just wanted to start off by thanking you all for doing this work. I sometimes joke that I feel like Tyrannosaurus Rex, like I have a big mouth and small little hands and can't do the work that is needed to be done without you all helping to explain it, ask really important questions, and get the information out there. There are so many different ways I thought about like sharing a little bit of my perspective and where I'm at. I'm not a journalist. I'm not a reporter. I don't have the mad skills that you all have, but have had to kind of step in and try to do my best as I am explaining information to patients and to the public as a whole. So what I did is I put together just a few slides to kind of put a little bit of context in when I think of rural health and Alaska as a whole, but I really want this to be an interactive question and experience in many ways as possible. I want to serve you to make sure that you have the resources and skills that I may have or have stumbled across along the way to provide you. So there's no question off limits. Feel free to ask me anything. I want to make sure that this is as useful as possible to you. So I'm going to go ahead and share my screen. And can you guys see that slide's okay there?
Yep, that's showing up for us. Thank you.
Great. Okay. Well, I was putting these together quite quickly and stole someone else's title. Why should I trust you? This is a concept and a podcast that is now around by Brinda Arcardi. And I have really been thinking a lot about this concept. Like, why should I trust you? Why should I trust my healthcare provider? Why should I trust public health? Why should I trust media? And how we are able to build trust in a two-way conversation. And so I decided to kind of focus that for the title of my slides. I also usually end most presentations with this picture. I absolutely love it from the city of Utqiagvik, which was once called Barrow, the farther north point of North America in Alaska. And this is what we call blanket toss, and it's usually a large whale skin that is used to toss people. It's just a lot of fun. But the reason I end presentations with this is to think about the ways that we all have our different hands on catching each other and providing health, but that it should also be fun and engaging and entertaining and locally relevant. So I decided to start actually with it here first because I think that you guys really have your hands on this blanket of health and helping to connect the dots, tell the stories with really that patient, that reader at the center of what you do, and thinking about making sure that all sides are held so no one falls as we move forward. So just wanted to provide a little bit of who I am and kind of who I am in context. I'm a practicing emergency medicine physician who thought that's what I would do. And I quickly realized that the definition of insanity is doing the same thing over and over again and expecting a different response, which is the emergency department. You know, you get the same problems over and over again, and you expect somehow it's going to be different. So I quickly realized that if I was going to care for my patients, I needed to care for larger systems of health. And so started to become involved in our group and then our hospital and then our state and then federal efforts to try to improve systems of care. I really began to realize that all good public policy comes to fail in the emergency department. And so a story, a person, a place is the example of a housing crisis, or how their medication was unaffordable, or maternal mortality rates. It isn't just a statistic, it's, the patient in bed 12. And so being able to connect those patients who really my reason why with policy, which is my how, is really, I think, my life's calling and in my work and in my space. I started to go to too many meetings until I got asked to run too many meetings, and then became the chief medical officer for the state of Alaska, somehow perfectly timed 6 months prior to a worldwide pandemic, and stood in that role for 5 years. It was the honor of a lifetime. Learned a lot about communication during that time, continued to learn a lot about communication since that time, and represented all the states and territories at a federal level. And for, as I'm sure many people remember, there was a, daily press conference for a long time. And then we really switched into actually a Zoom format where we Zoomed once a week with the public and the press to answer questions. I really believe that communication is a two-way street. It's as much listening as it is speaking. And so those Zoom really gave us a chance to hear deeply from the public, from the press, from our policymakers on what they wanted to know, and our team be able to share. And just like in the emergency department, I am not the orthopedic surgeon. I'm not the cardiologist. The same is really true as a public health official. I'm not the epidemiologist. I'm not the governor. And I'm not the hospital administrator. People still, think I'm all those things and blame me. And I oftentimes joked that I had no power or authority in Alaska. I only had the power to Zoom. And so the importance of communication was key in that space. So when I think about key drivers for health, and this came back from work that I did a long time ago on opioids and opioid work, I think about that if I'm going to make any significant change in health, I have to engage five major, what I call the five Ps: providers, patients, the public, policymakers, and the press. I don't think everyone thinks about it this way. A lot of my healthcare providers and public health providers really honestly see you all as the enemy, something to be avoided and not to be discussed, to engage with, but really focusing on the policymakers. In almost every health policy question, I see two people pointing to each other and saying, if only this one was different, then the whole system would be better. But I really think it takes all five of these to make any systems changes. I'm working on a big data project now with the Yale School of Public Health and really trying to democratize data. So you all have the information that you need to be able to report on health data and health metrics, but also the governor and the state health official and the doctor and the patient also have information that they can make decisions about their own health. But I was working on this recently and I'm like, I haven't involved the public as much as I should. Like, who are the patient advocates? Who are the really energized public who needs to be behind this project? So I use this as a back check. And I would oftentimes emphasize this with policymakers as well as the press. I'm like, okay, you've talked to me as the policymaker, but have you talked to patients about this? Have you talked to providers? Have you talked to patient advocates in this space? Because they're going to have a different perspective, and it's going to take all five of us to move it to change the space. I couldn't get this thing to change off of arrows this morning, so this is not meant to say one leads to something else that was better or supposed to be blocked, so I apologize for my inability to make the slide different this morning. But I was thinking a lot about this recently in the ways that we communicate information, and this has to do with how we communicate risk, how we communicate limitations, and how we communicate how definitely we know about things. And I think our different skill sets and our different roles that we have in society have us sitting along different continuums of this communication. So I think of the scientist as the far kind of left to the side, and they're really thinking about, I used to joke with my epidemiologist, their limitation of limitations. Every single paper you ever read from a scientific paper has a whole series of why this is limited, why more studies are needed, why you can't extrapolate this. And this is really important for us to know that data needs to be replicable. It is only telling one bit of the data based on what they saw or what was observed or what question was asked. There are limitations in how well that is extrapolated. I oftentimes think of the Plato's form, how there's some truth out there, but we're all getting to it in slightly different ways. And so scientists are trying to get to that truth of how many people are vaccinated, or how many COVID cases there are, or, how healthy is my population, from all sorts of different angles. So that's just like a very kind of conservative way. And I think on the very far end of that is like a defense lawyer who their job is to be able to argue either side of the story. It is not to get to quote the truth, but it is to find statistics or information to really drive a point and a data to say, this person's guilty, or this causes this, or, we need to remove this out of the food system or whatever else it is to drive a point. But then I think clinicians, public health officials, and honestly, the press sit along a different continuum. And oftentimes I find that we get mad at each other because we're sitting along different parts of this continuum rather than recognizing all of these parts of the continuum are needed. So I, as a clinician, really have to, I think, sit side by side with my patient and say, this is the risk, this is the benefit. What do you want to do? You know your life experience in a way I don't, but this is the information. But I'm also expected to lead that space, not just be like, it's a menu of options. What do you want to choose? I have to, say, I think this is going to be best, or I really think we need to do this next, which is going to be different than a scientist. Public health officials are giving that information to an entire population, which is really hard to transition to as a clinician, whereas as a clinician, I can know a person's individual priorities. I can know their past medical history. But as a public health official, I got a lot of criticism of like, I'm immunocompromised, or I had an adverse reaction to vaccines. How dare you tell me I should get vaccinated? Well, for you, that probably doesn't make sense because you've had an adverse reaction and that can totally happen. And nothing we do in life is 100% safe, including vaccination. So trying to mold an N of one to an N of, whatever population you're representing can be really, really challenging. And that's where I actually think public health officials and press sit quite closely together. I think public health officials really look to their clinicians and their scientists for the space. And while you all do as well, again, never having sat in the press space, you also need to tell story. You need to have it engaging. You need to be able to, you're trying to make a point of it. Oftentimes I would get feedback from journalists of like, I'm trying to tell this story. Help me understand this so I can tell it. So while it's not a lawyer, it is trying to kind of tell a whole perspective and to connect those bits. So I put you all in this context because I think from my perspective, helping to understand these contexts helps me to figure out how to engage in a more meaningful way. I think we all think about this in different ways, but navigating this press and political divide, I had a journalist once say to me, but my job is to tell the truth to readers. And what I had to remind this really amazing journalist and reporter is yes, but you help to sway the public narrative. And the public narrative is the power in which politicians sit. And so if a politician wants to get across a bill or an effort of whatever else, they need the public behind them. And so they need to tell their story. They need to make sure they're getting out there and encouraging people and senators and representatives to vote for X, Y, or Z. And so if the press is telling a different story, that may be actively taking away their power. And that doesn't mean the press shouldn't do that. I think it's just understanding that our incentives are different in different places. And so being mindful of that. And part of the reason I bring this up is as a public health official, I work at the behest of my governor. And so while I'm an independent person and I can, say what I want to say, I also like represent when I worked at the state, I represented the governor and his team. And so what I could and couldn't say may be influenced by that and or maybe stuck in those positions. I feel very, very fortunate. I worked with a governor who said very clearly I will never tell you what to say. But you're not the governor. You can't, tell me to require a mask mandate because I'm not going to mandate that. And so that was his decision to make. And he was very clear that he would never try to interfere with science being spoken. But that is not true for every state health official. That's not true for everyone in my position. And part of the reason I do believe that I was able to stay for as long as I did and left just because I felt like I could do new work and other work in different places was because I felt like he gave me the latitude to speak science as it was coming out and I was there, and I was able to let him do his job as being governor rather than confusing or crossing those roles. So I share this in terms of like when you're speaking to public health officials or healthcare providers, knowing some of the constraints that they're under. And along those lines, like on this next slide, really talking about kind of the incentives and the risk to talk. And I'm sure you guys have all had experiences by this. But as a healthcare provider and as a physician, I may want to help change the system or share kind of the moral injury of what I'm seeing. It can be really, I remember when I first started working as an emergency medicine physician, I would go to the grocery store and just walk around and see how many like not hurt people there were because I just spent my entire day seeing how many hurt people there were. Like we are all biased by our experience. As a healthcare provider, I am so biased by emergencies, emergency department, that world, because that's what I spend all day doing. I would have to like really pull myself out of that. So sometimes just sharing that and helping people to see that is part of the reason we speak. But there's huge risk that comes with that, including potential liability, job loss, going against your employer. I think we've also been taught for a long time as healthcare providers that, you don't work with policymakers, you don't work with politicians, you don't work with the press. Like your obligation is to patients first and foremost. And I've gotten a lot of pushback from press on that. We're like, our obligation is to the people that we serve, to our readers. And so therefore we're aligned in that space. And I'm like, yes, and sometimes the information we have, most of the time, the information we have is, covered by HIPAA. We cannot share under any circumstance. And so there's this feeling of like, I'm going to be asked to violate my oath or a federal law by being able to share. So I just highlight that for like when you're thinking about talking to healthcare providers, just acknowledging that tension that they're under. And for public health officials, similar sort of way, there may be a real incentive, or their, leader may have said you are not allowed to talk to press under any circumstances. Many of my, colleagues that I work with on a regular basis they've gotten burned and they've said, I'm just never going to work with the press. I have no desire to ever talk to them. I personally had a very different motto because I felt like the press is a really important way to tell the public what is going on and to be truthful and to honest and to make sure that they are empowered to make informations. But I've seen so many people feel like they've gotten burned in that space, that they've really moved away, and or very, I wouldn't say controlling, but very kind of, executive branches that are very clear about who can talk to what and what can say. So they just really may not be able to do that. So just, I want to highlight some of those spaces. And then I wanted to highlight some areas where I really think that there is real ability to empower experts to speak. So one thing to recognize is, and I think you all probably know this, but like scientists and healthcare providers often have had zero training ever to work with the media, and a lot of stories and reasons why never to work with you all. So it can be really challenging to effectively communicate a complex information to the public. And I think there's more effort to be able to do that, but just recognizing that up front. And some tips that I have given my staff, or I've actually given media when they've been interviewing my staff, is like, for the next thing is provide a roadmap, such as telling them, tell me a story that brought you to this decision. Why is this information really important for the public to know? Like, help them help you tell a better story, because they may have a really great story in their back pocket of, a community that chose to address diabetes together, but they are used to presenting at, say, a scientific assembly where it is, here's the data, here's the background, here's the information, and here's the limitations, which is very different than an engaging story or why the public need to know. And so know that a lot of their training is in a very scientific presentation rather than that. So help them out in that sense. Offer people a second chance if you ever have the opportunity to provide additional context or feedback. So it can be so helpful when a reporter or journalist comes back to me and they say, you shared this, I went and investigated, I found this other information, and they had said X, Y, or Z. Like, do you have a response to that? Does that fit with what your experience looks like? I'm like, oh, I had no idea that you were going that direction. Sure, I have all this other information that helps to support that. Or I would have told you these other things if I had known that was the direction that you were going. So sometimes I feel like interviews are these very kind of like I have to ask you about this, and it's kind of open, but now like, I feel like press sometimes really hold their cards where they don't want to share. And I get that. And again, I am not a journalist, I'm not a reporter. But I have found that particularly with like really high end quality journalism, they will oftentimes follow back up for additional information that I think makes the story at the end of the day more complete, because it helps us all kind of be in that, holding that blanket tossed together. It helps us all hold that story and share the different perspectives, rather than kind of keeping our cards so close. I can't tell you how much expressing gratitude, really to speak with the press oftentimes for us is a huge risk. And so just thanking people for that, I know this is hard, or I know that, you don't always do this, or, this took up extra bit of your time, but just that little bit of humanity, can make a really, really big difference. And, something again that I see when I've worked with everything from incredibly small journalists to very large journal, organizations, and, really good journalists, make it really easy to feel as though you're helping them and you're putting time and effort into their space, and that you're developing and degrees a relationship. And then if you can in any way, provide the story back to them. So I know, you usually don't want to share quotes back. You don't want to have those specific things, but even like sending a link like, hey, your article was published, or we ended up not choosing to include this, but here's the story that's there. If it's behind a paywall, providing a PDF, if you share it on social media, asking them if they can link you and then linking you on that space. It's incredibly frustrating to spend like a lot of time with a reporter and then start to get texts from friends or the governor or someone else that, a story or something you said was, I had an example recently where I shared some perspectives about some budgetary changes that had happened in a story that ran, also had talked to an anonymous source, but the way that they had linked us together in the story, they never said I was the anonymous source, but they said Dr. Zink said X, Y, or Z, and then they said this anonymous source said, MNOP, and how does this, like these are the things we're concerned about. There was a lot of concern that I had shared or leaked documents, which I had not. Like my policy is I will never speak on background. Like I am just, you get me, you get all of me, because I never can tell when something's on background or not. So I'm going to tell you as the same thing I'm going to tell the governor, which is the same thing I'm going to tell my family, which is the same thing I'm going to tell my patient. And it's easier for me. So that's my philosophy in that space. So I'm never going to speak to a reporter in an anonymous fashion, but that's me. And that's not a lot of other people. But people had thought that I had access to information, which I hadn't, and had shared it, and were very angry with me and were like, we can't talk to you, we can't partner with you again. So it actually got me in a lot of trouble, even though I had nothing to do with this anonymous source in the way that reporter had put them together. And I think if she had said, we have this anonymous source, can you confirm or deny, or how that would have helped. But I also think just if she had texted me the story, like I would have known about it prior to getting, calls from people saying, why haven't you done this or this? And it took me a minute to like get the story and to figure out what had happened to put it into context. So just let us know when it's out there before we're like then inundated with people and questions overall. Okay, we talked about that. Let's see here. For some reason, my slides are a little bit slow here. I just wanted to highlight this too. Like, I know it takes a lot of time and effort, but building those relationships and maintaining open communication, providing feedback, if you got a lot of really good responses or you get, I recently did a whole project and podcast based on feedback a reporter I've gotten to know had gotten on another paper he'd written. He's like, a lot of people are asking this question. And I'm like, oh, I can dive more into that and bring these experts. Actually, this other reporter, I ended up having him on my podcast and he ended up like interviewing me and I went back and forth because I think like we've developed a really good rapport and relationship, but really kind of like fostering that trust and collaboration. I also think it provides a great way. I can't tell you how many times I would, tell a reporter, like, I think this is going on, but I'm not really sure, but I have a sense of this. And then they ended up being able to be this huge resource to me because they would then go research it, try to figure out if it was, and publish a story on it. And I'm like, oh, that really was the case, or that really wasn't the case. And so they were able to really help foster the conversation about public health, which I really appreciate. And this is an example that I share oftentimes is, there's been a lot of great resources in publishing, but this is an example of what I thought was really great reporting. And I use it almost in every presentation now when I'm sharing. This is in the New York Times. But the reporter had asked me like, what are you struggling with? And I'm like, I'm really struggling with the 1918 pandemic and the history and trauma of how many Alaska Native people died from that. That is the context in which they're approaching this pandemic. And so saying like, oh, don't worry, we have a PCR testing, like that doesn't translate well into Alaska Native community and culture and history. But we're really trying to take the science and information we know about vaccination and testing and trying to also just really acknowledge this historic trauma and culture and context that has happened. And so he ended up doing this article called Alaska's Remote Villages, A Race Against Time and History, which I felt like just really did captivate and like capture what I was feeling and experiencing, and so many of us were. And he interviewed, people in different communities. He told this really beautiful story. I wasn't once listed or named in it, but this was an example of where a reporter was asking me like, what's struggling? And he went and did this kind of other deep dive and research. I ended up sharing his article a ton because it really helped to share the perspective that I was experiencing and feeling. A lot of Alaska Native people who were part of this context. And I feel like it's helping to tell the story of what happened. The 1918 pandemic in Alaska is referred to as the Great Death. And I really hope that we're able to look back on COVID as the great resilience and the ways that communities were able to work together. But that narrative really happens from the oral storytelling and the written word that is a big part of our history, which you guys are fundamental to. So that is just a really quick overview. I just want to thank you for what you all do. You are the voices of people, and that is the voice of change. And we cannot do what we do without you. And so why, when I was asked, I of course had to say absolutely. So looking forward to the conversation and any questions that people have.
And thank you so much for those really, really helpful insights. It's such a great reminder to us as journalists to think about the impact we have, as the press and as such a key piece of what you brought up. I want to make a reminder to our audience that you can share questions in the chat or the Q&A function. Of course, we want to hear all of yours. I'll just get us started with a question. And of course, you've been a major public health official in Alaska, one of the most geographically challenging states for healthcare delivery. How did that experience shape your understanding of rural health disparities?
Yeah, I mean, so many ways. So Alaska is bigger than Texas, Montana, and California combined. We have more coastline than the East Coast and West Coast combined. And on my second week, I was in a village and was meeting with a team of people. I was excited to think about how we could reduce healthcare disparities, reduce healthcare costs, increase access. And I met with some leaders and I said, how can I help? Like, help me understand this. And this woman said, you represent God and government, everything that I cannot trust. I have no desire to work with you. And I was like, okay, that's pretty blunt. But it really helped me to see that I was stepping in to context that I needed to respect and understand that, while I was not my predecessor, who was an amazing person, but he was also, we all stood in this line and honestly represented government, which had really been very detrimental to that community in many ways. And that was a humbling experience that helped me kind of then reframe, I think, more of my conversation. I said, what can I do to build trust? And she said, you could live here 20 years. And I said, well, I can't live in every community 20 years. And the reality is I only have so much time and you only have so much time. So we can either choose to work together or we can choose to let our hurt and our past dictate our present. And she and I became good friends and started to work very regularly together in that space. So I think acknowledging limitations really early on is really important. Like as a public health official, there's a lot I don't know. I have no idea what her experience is like. When I'm meeting with a patient and a mother, and the mother's like, I'm really worried. I'm like, I will never know your baby like you know your baby. So you tell me what is best for like what you're worried about, and I will bring to you the science information. And I think about taking that approach in a very, very similar way. I also think that getting places in context and story. So, for example, whenever we had a new COVID case in a small community, we have again, people travel on the average 150 miles to access care. People, okay, another pivot point for you all reporters out there. If you're going to talk about the United States, don't leave Alaska and Hawaii off the map. Can I tell you how many times I would go to a national I'd be getting emails from the federal government, like, make sure you come to this webinar. We're going to share the data on X, Y, or Z. And I'm like, I'm not even on the map. Like, just don't leave off the map the people you want to have a conversation with. So first of all, that's super
Yeah.
important. And
Mhm.
then, just all these websites that are US data and we're not on the map. It just how many times we're not on the map is really, really frustrating to Alaskans. But I saw that a lot in rural communities. I was just meeting with a team and they were like, well, this is how we're looking at all the national data and here's all the cities. And I'm like, well, how about the people not in cities? So be aware of where you're not showing that context. So for example, when we'd have a COVID case, we would say, who are the natural leaders in your community? And usually it was a tribal leader, a healthcare leader, and a municipal leader, someone who was elected. And then we would say, what is the most common way that you all share information? And it was either Facebook, radio, sometimes TV, and occasionally ham radio. And then we would say, okay, how do you want to present this information? And we would get towns and communities that were like, we're scared. We don't want to do it. Can you just be there? And then we'll answer questions. And we're like, sure, no problem. And other people were like, we don't need you. No one trusts you. No one's ever trusted you. And
Mm.
so we want to lead. And we're like, great, what can we do to help? They're like, when we don't have the answer, how are you going to get more testing? We're going to just turn to you to solve all the problems we can't solve. And I'm like, no problem. We can step in that space. Or when I was in Uphiavik, we went up there and they were like, where are your men? And I'm like, they're doing epidemiology, back in the state. And they're like, we look to our whaling captains who are always men. That is who we trust. We don't trust you. And I'm like, totally fair. I'm like, where are your whaling captains? And so we met with the whaling captains, and the whaling captains are like, okay, we have a regular radio show where we provide information. Will you come on there and we'll talk about stuff and we'll ask you about what else you know? Absolutely. So
Mm.
it's not about your voice, but it's about empowering those who are locally. So I think that's another way when I think about rural and indigenous health is about how to just get the information to local people, or that's why I bring up that story specifically about a race against time and history. Like it was told from their perspective, not my perspective. And I think that that just really resonated with people much better.
Thank you. And we have two questions actually from the audience. So, someone wants to know what resources or sources do you think are the most reliable, given that there's so much information out there?
I mean, I think that that is like 99% of the job, right? Like, what is the reliable information? I mean, in emergency medicine and in healthcare, they always say if you're unsure about a patient, go to the bedside. And I think that the same really applies to communication. If you're unsure about the data source or who you're talking about, just go to that community or that data source and ask them. Like, I, as an emergency medicine provider, will be able to tell you a much different story about admit discharge data information than I would be for the CDC for syndromic surveillance data. And so I think it's important to ask the people who use it to understand what is most trustworthy and reliable, because there's a lot of variability. I mean, for example, like, again, this data system and set that we're working on, we were looking at the National Immunization Survey for vaccines versus the Epic Cosmos data versus immunization registry, and they tell completely different stories. And what's true in Wisconsin is a really different one than what's true in Seattle. So I can't tell you like, here's the one data set and source to look at. I think going back to that scientific side, there's limitations of the limitations. There's limitations to every data set and story. So I think you have to ask yourself, like, what am I trying to solve or what am I trying to say? And then am I getting as many data sets and stories, be it the firsthand lived experience as well as like the clinical data, the public health data, to be able to see where there's differences and similarities, because I think that's where we find the truth.
And a question from Natalie. How do you in your work help to bridge the gap in information sharing with news deserts where resources are few and access is getting smaller and smaller? Great question, Natalie.
It is a great question, and I think we struggle with this in so many different ways. I think people will get their news from something, but oftentimes they are news deserts and they're very small. So they're getting it from TikTok, they're getting it from social media, they're getting it from different areas. I think as a public health official, so take something like a sexually transmitted disease, we started to very much involve like Tinder and try to involve social media where people were at. I think a lot about like meeting people where they're at and providing information in those spaces. I also think, you know, I'm not a huge person on social media, but uh, very quickly on in the pandemic, we switched to kind of from press conferences to really switching to just communication in other ways. So we set up, like I mentioned, those weekly Zooms, but then I just like Facebook is like huge in Alaska still. Like, I go to other places and, it's so old school, but in Alaska, like that is how like everything from like, where's my cat to like, have you seen like the changes in this airplane? Like, so all information is shared. So,
Hmm.
I ended up opening like a professional Facebook website to really kind of bridge that. I posted this weekend on a new measles case that happened in Alaska because I was like, there are a lot of people follow me. I really should do this, even though it's not my job anymore. And for Alaska, like it got shared a ton, just because that is where people are getting their information. And so that's where I really like working with reporters. That's why, like, if you text me your article, I can then reshare it on my Facebook that's already linked. Like I can help bridge that gap to that desert if that information is relevant to that community and space. So that's why, like, I was really emphasizing, like, even if you're doing a national story or you're doing a story about a local region, but it's not where you're always at, you may not have the following, or your paper may not have the following, but it can gain traction by sharing it with those who you shared the information to. And you may get more people who support your readership or information later because they found that helpful. So that's why I think that that two-way sharing of information back is really important for these deserts, because we know where information is happening. That's harder to know at a national level.
That's such a great point. I think every time I've ever shared a story with a source after, if I've remembered to text it, which almost set a reminder, it's always either led to more stories or just better connections. So I imagine that's incredibly important in, more isolated communities, especially. We have one more time for one more question. We have one in the chat. Are you finding that data sets you have depended on have disappeared or been deleted? And maybe how are you, if so, how are you dealing with that and pivoting?
Yeah, it's a great question. I think, coming from an Alaska State Health official perspective, I think a lot of the data sets were really, really limited and really frustrating prior to recently. So I was kind of angry about the data sets prior to it. Like, I'll give you a very concrete example. When the state of Alaska, when the CDC rolled out the hospital risk stratification score for COVID, they did it based on these quote hospital health zones, but they didn't tell us how they calculated it. They didn't tell us any of the information behind it. It took us 3 weeks to figure out that information. Turns out Alaska has three. And so when you have two people from a nursing home that were moved just across the hallway to the hospital because they developed COVID, suddenly our hospitalizations in that zone went up, which all took place on an island hundreds of miles away from the capital. But because the capital wanted to follow the evidence and data, suddenly they went to a red zone, schools closed, masks go on, everyone's angry during the capital, but it had nothing to do with their local risk. So I
Hmm.
guess I just would highlight the fact that like it's important that we have information and data. CDC's data is a tool, but it is also a very, very limited tool. And so I think I see a lot of national reporters really wringing their hands. And I'm like, yes, and there's a lot of limitations in that data
Hmm.
and that data sources aside. So I think you're seeing a lot of people standing into that. I think where now what I'm really kind of watching is in that, like, I loved the ACIP meetings because they were publicly broadcast and I could watch scientists go through the information and be able to see it. So is that going to still be publicly available? And the last one was where we could watch it. So like, what's that going to look like? So those data sets I think are important. I think a lot of survey data work currently isn't being funded, but we haven't really seen the impact of that for the next set of data. So I think our survey data sets are probably the highest risk data sets right now that we can't really recreate any other way.
For sure. Well, and thank you so much, and to our audience for these great questions. We'll share a link to the recording soon, along with resources shared during this briefing and more. The National Press Club Journalism Institute is proud to produce programs like this at no cost to journalists across the U.S. with the mission of powering strong journalism in the public interest. If you'd like to support us in this work, we hope you'll consider making a donation today, and the link is in the chat. Please spare a few minutes to fill out our survey, tell us how we did today and how we can improve our future programming, any ideas you have for what we can do to help journalists and professional communicators. This webinar series is part of the Institute's Public Health Reporting Fellowship, funded by the Common Health Coalition, which is a network that brings together leading health organizations in pursuit of a reimagined health system in which the nation's healthcare and public health systems work hand in hand. Thank you all so much for joining us. Thank you, Dr. Zink, again, and everyone have a great rest of your day.
Thank you.